In June of 2026, the Society for Advanced Bronchoscopy hosted a program titled Navigating Lower Cancer Risk Nodules in High-Risk Patients with Non-Invasive CyPath Lung Testing. This podcast series is derived from that program. In the first episode, Dr. Robert Sussman, a pulmonologist, moderated a multidisciplinary panel composed of Dr. Sai Gouda, an interventional pulmonologist, Dr. Reginald Baptiste, a thoracic surgeon, and Dr. Vijay Gunagante, a medical oncologist. They discussed the growing challenge of lung nodules and how non-invasive CyPath Lung helps clinicians risk stratify with greater precision. In this second and final episode, they'll discuss real-world cases, multidisciplinary collaboration, and the future of lung nodule management. As this episode opens, Dr. Sussman is talking with Dr. Baptiste about the critical role of thoracic surgeons in some parts of the country for obtaining tissue biopsies. Let's listen in.
You made a very good point, Dr. Baptiste, that there are lots of places in the country where there's no availability of advanced bronchoscopic techniques. But I think even when there are, we know there are some cases that just can't be diagnosed, and you're still, I know I did, and I'm sure many people on this webinar have patients that they sometimes have to refer to a thoracic surgeon with a high suspicion but no tissue diagnosis. And I think you have a few cases, especially one that you want to highlight in that regard.
Yeah, it's not a failure to refer to a thoracic surgeon. Let me state that emphatically right now. This particular patient, it's a very good patient, 80-year-old lady who quit smoking in 1999. She had COVID during 2021, had a previous stroke, hypertension. Overall, she's good performance status, has symptoms of cough, asthma, shortness of breath. Her initial chest x-ray showed a lobulated opacity in the right lower lobe that Dr. Downey took notice of and followed very closely. And she had a number of tests, low-dose CT scan in 1023. She had a PET scan, which showed a SUV of 2.5. The lung probability was calculated as 15.9%. She requested to be followed closely, and she had a repeat low-dose CT scan, which showed no changes in the right lower lobe nodule. However, in 2025, there were some changes in the right lower lobe nodule, and that was concerning with Dr. Downey. And at that time, he performed a blood serum marker, a notified test that showed a reduced risk. Her bronch score was 15.9%. Bronchoscopy at that time really didn't show any suspicious activity for malignancy. And in addition, she had a second bronchoscopy about 5 to 6 months later, which again showed no suspicious cells. So he performed a CyPath Lung study, and it was likely a malignancy. So he had a long talk with the patient, and she elected to have an excisional biopsy, for which we did a robotic resection in 2025 of June and showed a early stage neuroendocrine tumor. So I think this case really kind of swung the pendulum to surgery pretty convincingly after the CyPath study test. And I think that was extremely helpful in that regard.
Very good, thank you. Dr. Gunagante, as an oncologist, you will typically be seeing patients after they've been diagnosed, maybe after they've had surgery, or maybe they're non-surgical candidates. I do understand that you're also involved to some extent with lung cancer screening. How has the use of CyPath impacted your practice?
Oh, definitely, as I was mentioning before, look at Paula from January 2024 to 2025. How much anxiety we as clinicians, are we 100% sure it's not cancer? We are not. We tell the patient, well, does not look like cancer, smell like cancer, walk like cancer, but still we want to do a scan in 3 months or 6 months. gut feeling. We go with the gut feeling, like a clinical um, information we have. But since CyPath came on, that anxiety has much reduced in a lot of my small nodule patients. And I also use it for my oncology patients where we do scans every 3 months to make sure the cancers are not coming back, which Dr. Guda has alluded before with other cancers. When we screen them, we are finding more of these nodules. So when we see a 6 millimeter to 1.2 centimeter mass, which had a diagnosis of lung cancer, breast cancer, kidney cancer, 2 years ago, we are in the gray zone whether is this the same cancer or is it a new one. In that, it has helped a lot. And also in the screening, I remove that anxiety. The patients are not at anxiety. Okay, doc told me there's a nodule. The navigator called me saying that it could be cancer, it could be benign, it could be nothing. So with this test, it has decreased a lot of anxiety in a lot of my patients, even though we are not going to subject you for biopsies, bronchoscopies. At least let me do this test and reassure you. I want to make sure it's negative. Most of the time, the negative predictive is so high, and it helps me like, okay, I can reduce the anxiety saying that, okay, it's not that suspicious, both clinically and genomically. And I can tell you that we can safely sleep at night. So that has helped. And the second thing is when these patients like Paula come with a 1A stage, I first thing they ask is, did we catch it early? Even the oncologist, what is my prognosis? Then I say, okay, you have a diagnosis, we need to do staging and the treatment options, and the step 4 is how does this play a role with your life? At that time they feel happy that we caught it early, and that's what resonates everything. All their family friends are saying, did you catch it early? Check with your oncologist. So all these things reduce their anxiety, give us answers quicker. And as Dr. Baptiste said, maybe we should, like in Japan, the incidence of colon cancer, gastric cancer is so high, it's like a drive-through scopes. This is more invasive. Here it's just a sputum test. Hopefully we can use it like Cologuard in future at some point. Yeah.
Thank you. Dr. Guda, obviously you've had the most experience with CyPath of any of us. Why don't you tell us a little bit about that and how it's made a difference? And I think you want to show a case study as well.
Yeah, so I think the one thing that I do want to mention is either you have a clinic and a practice that is for performing biopsies of nodules that are small or challenging, or you have a clinic that is relatively more avoidant of those. I mean, there's something in between. Our practice, like I said, we have a very large practice of patients that are coming in at a higher risk. So when we risk stratify patients, we are careful about which ones we select. A lot of times, there is limitations to CyPath. The sputum production has to be good and all of that stuff. And some patients are unable to tolerate it, even though we want to get them the right testing. In our community, because we have a lot of tobacco use in Texas, as we know, there's a lot of ground glass nodules that we get called in for. And ground glass nodules is one of those bastions of pulmonary lung disease or lung malignancy, where you want to be accurate when you're performing biopsies for these. And with the advent of the older methodology of forceps or a needle, you're not going to be getting enough tissue to be able to make a reasonable diagnosis. And usually it's like atypical cells, and atypical cells are quality not sufficient, as our oncologists are very familiar with. So now with the advent of cryobiopsies with robotics, and we are able to do more tissue, get more sampling. However, there's a risk associated with it. There's a risk of pneumothorax, there's a risk of bleeding. So when we consider patients that have got ground glass nodules to take for this, it's very amorphous. The tissue is very light. There's nothing solid for you to stab into, and nothing holding it together. You have to take the right patients for this. You can take a patient that has got really significant lung cancer history or in the family and high risk of smoking for ground glass nodules, and the next thing you know is all you're doing is you're getting this alveolar tissue. But in this one situation, we had this patient who had this ground glass nodules. We changed her name for the sake of anonymity, but this patient, Helen, she had this ground glass, maybe part solid, hard to tell, that had been kind of, she had former smoker. She quit about 5 years ago, but she had a significant smoking history. She had quite a bit of anxiety associated with this nodule. Her brother died of lung cancer. Her father and mother both died of lung cancer. They were coal miners. She was a smoker. So there was quite a bit of anxiety associated with this. And this was one of the initial times when CyPath had just started making its way into the community. And I was a skeptic, which is a good thing to be when you have new technology coming in. As a skeptic, I subjected the test to the patient, not the patient to the test, but the test to the patient. And it came back as a high probability of malignancy. It's negative predictive, but I was more interested in the negative predictive value. And we went ahead and discussed that with the patient. She was obviously anxious about it. So we went ahead and performed the biopsy, and it came back as adenocarcinoma. And she ended up going for a lobectomy of the right upper lobe. And then lo and behold, she's thus far cancer-free. And when it came back to the community and we were talking about it in tumor board, the question, obviously, the radiologists were like, what is different about this compared to every other ground glass that we have discussed in tumor board that you decided to perform a biopsy on this? And what we found out is the difference is just CyPath. So here, where you have the higher probability of likely malignant on the testing, that is the only thing that gave us the answer for us to pursue biopsy here. And lo and behold, we have a patient that essentially at this point, thus far, is cured of lung cancer. So that is some of the ways in which this has been able to like help justify performing biopsies on patients that are coming in with less than amorphous nodules per se in our practice. But to reflect back on the cases that have already been discussed, Dr. Baptiste would probably have taken that patient based on the pulmonologist saying, hey, listen, I'm really suspicious about this nodule. I want you to take this nodule out because there's a high risk, but she's also 80 years old. So you're trying to risk stratify a patient that has got some other comorbidities. This really is helpful in those situations for sure.
Now, I want to take a little bit different approach. We've seen a couple of cases already and heard about cases where CyPath Lung was used to help diagnose early stage 1A lung cancers, obviously our goal to do so. But it also can be useful, as we've talked about, very useful for its negative predictive value and taking cases where we otherwise may have biopsied and being able to use this test with its very high negative predictive value to hold off on biopsy. This is a case, it's not my case, it's a case of another pulmonologist next county over from me in New Jersey, Dr. Diane Nadaraja. This was a patient that he saw, 70-year-old woman, big time smoker, 50 pack years, actually still smoking at the time he saw her. High risk for lung cancer, obviously based on her smoking, also had significant emphysema, as we know, another risk factor, actually independent risk factor that further increases the risk of lung cancer, but at the same time increases the risk of complications when we attempt to biopsy these patients. So he did the usual initial workup, CT scan, as you see on the top left, with a lung nodule, PET scan that was positive, mildly positive. Risk stratification using currently available techniques. Mayo was 91.3, others were anywhere from 50 to 90. So for all intents and purposes, this is a lung cancer. New nodule, PET scan positive, risk stratification predictors said this was lung cancer, but he also was using his clinical gestalt. Something didn't seem right. This patient presented with really new onset cough and sputum, no fever, no other obvious indicators of infection. But he was concerned. He was concerned about doing the biopsy, high-risk patient with significant emphysema. So he used CyPath Lung, which came back low likelihood of malignancy. As a result, he opted to wait 3 months, repeat the CT scan, complete resolution of the nodule. So again, negative predictive value is very strong with this test, and it can be used in some cases to reassure patients, even when you know that this is, I think Dr. Guda's term was a junk nodule. Patients are very concerned. They've been sent to you because of suspicion of lung cancer. Sometimes it's helpful just to have another piece of data besides you telling them, this is very unlikely to be a lung cancer. But I can do this test which has as we know, a very high negative predictive value. And when it is negative, confirming our suspicions, it also helps reassure patients that waiting is okay. I think we'll move on to the future. Where are we going with this? We know that the numbers of lung nodules are increasing. I mentioned that already, 2 to 3 million, if not already, certainly in the near future. Risk stratification is key. Biomarkers are going to play an ever increasing role with non-invasive testing, as with CyPath. Dr. Gouda, why don't you tell us where you think things are going over the next few years?
The future is a little bit hard to predict, to be honest, Dr. Sussman. But in the world of lung nodules, I think, like I said, I think people fall into two categories. Either you are a clinic that is getting a lot of good nodules that are early risk cancers, that you want to perform biopsies on them, and you want to rule out the ones that you don't need to perform biopsies on, or you are a clinic that sees a lot of nodules that are essentially coming from the community that are junk nodules, or as I have mentioned them, or you're like, I'm not sure if I should be performing a biopsy on every single one of these because these could be granulomas and so on and so forth. And I think the future is a little bit more, in a sense, it comes down to the kind of practice that you have. In our practice, we talk about risk stratification on every single one of the patients, and not necessarily to figure out which ones we don't want to perform biopsies on, but for those that are coming in with solid tumor history, or those that are coming in with a nodule that doesn't fit every single box, would you consider performing a biopsy on this? So in the future, I think a lot of that is going to come from primary care physicians. They're saying, hey, listen, this is the data. I already have a CT scan because that's one piece of data. And then here's a second piece of data that says that you should be performing a biopsy on this. So you've already done a lot of the clinical gestalt and the work on the back end of it before the patient is getting sent to some of our advanced bronchoscopists or interventional pulmonologists, or CT-guided biopsy, depending on what's available in your resource pool, to get tissue. I think that is, from an investigative standpoint, from a procedural standpoint, I think that's probably where it's going to go.
We have a question that's very appropriate for our multidisciplinary panel, and I think I'm going to open the question to all three of you one at a time. How has multidisciplinary collaboration changed the way lung nodules are managed? And where are the biggest gaps still occurring? Dr. Gouda, we'll open with you.
This is something that we talk about all the time. We are in the current phase of medicine where every single specialty has something to offer for almost every single disease. I say this as a broad statement, and it's a little bit of a generalized statement. And there's always, like, some specialists that are like, nope, we manage all of this by ourselves, which is true. But when it comes to lung nodules, it's in a very unique position, because, like Dr. Gunagati was saying, you can have early stage diseases that you can actually just give chemoimmunotherapy, and then 25% of them are cured, right? So then the purpose of the thoracic surgeon there is a little bit more diminished in 1 out of 4 patients. At the end of the day, you still need tissue. So it comes down to, the first thing is the story of the patient. What are the risk factors that the patient is coming in? Is that story being disseminated evenly between all the providers, all the specialists? And that's why you talk about it in tumor-borne, in a lung nodule conference, however you want to design it, or over email in a multidisciplinary clinic. And then once you have that information, then you decide cumulatively, hey, do we want to risk stratify this patient first and then perform a biopsy or a tissue? Or do we want to go straight for surgical resection based on all the risk factors that you have thus far? Because, your PET scan is as revealing as it can be. Now, we also know that PET scans can have occult malignancies in the mediastinum and everything, anywhere between 6 to 21%, depending on your institution. And there's good papers to actually talk about that. So mediastinal staging is again important. But the question is talking about how multidisciplinary collaboration has changed the way how we manage pulmonary nodules. It has opened up the conversation and has given importance to those nodules that need intervention sooner rather than just sitting. When I was in fellowship, we had a patient who was a 43-year-old gentleman. He came in with a nodule that was 3 centimeters. Things got delayed because there was like poor follow-up. Eventually, unfortunately, by the time he actually got the tissue diagnosis, it was 6.5 months later, and now he was stage 4. So that is the patient that you want to avoid. That is a scenario you want to avoid, which is where multidisciplinary comes into play.
Dr. Gunagante, where do you see the gaps in these multidisciplinary?
So coming to the multidisciplinary collaborations, we have in oncology proved at every step of lung cancer journey, from diagnosis, pre-diagnosis, to surgery, and to do next-gen sequencing genetic studies. And then consistently, we have proved that survival is better with MDT than non-MDT patients. The risk of recurrence is less when compared to non-MD, non-multidisciplinary collaboration, team collaboration. So we have proved many times in many studies that using multidisciplinary collaboration decreases the risk of recurrence compared to a non-multidisciplinary team engagement, and improves survival when compared to if you don't do it. So we have proved it all. So definitely in nodule management, multidisciplinary collaboration has definitely is going to be a big one, because we can't just say, let's do this or that, but we just opened 5 emergency rooms, incidental nodule project, and we have an AI tool. We found 750 nodules in 1 month. We shut down the software because there's too many nodules we can take care of. We can't take care of that many. So we increased the filter from 6 millimeter to 8 millimeters. And that's when we don't have not too many navigators to navigate. So it's like, and then the second thing is, uh, how many healthcare systems have multidisciplinary collaboration teams in the United States? Not many. If you look at the workforce shortage in South Texas, not just San Antonio, where I'm from, South Texas, there's only 2 thoracic oncology surgeons who only do thoracic oncology work in the community, and only 2 at the academics. This is for whole South Texas. Okay. And then to get a pulmonary consultation for a nodule from primary care physician, it's not easy. So we need to use a test like CyPath to churn out these nodules. Not, even we have 5 pulmonaries, we go on round robin to get them all these nodules we find in the emergency room incidental nodule program, because we cannot get them to see, because most of the pulmonaries, their bread and butter is ICUs, right? They spend less time in the clinic. 1 week out of a month they spend in the clinic. How many nodules can you see? How many COPDs can you see? So, and I witnessed myself. I went to OR and saw the ion and EBUS procedure. It's like 15 people got involved for 2 hours. That's a lot of people. And then my pulmonary friend is like, why? I don't know. I could have seen more patients, in the clinic than doing this procedure. Look at this test. Like, this is a non-invasive. So going back to the future, we had a screening test for breast cancer. We had a screening test for colon cancer. We had a screening test for prostate cancer, 4 big cancers. Lung cancer, we barely got the low-dose CT scan. Why were they worried about approving? Well, we find these nodules, we keep poking them. Now we don't need to do biopsy of them. We can use the CyPath test to tell us whether we should do an invasive procedure. That was the most feared thing in the lung cancer screening trials. We're going to put needles on all these nodules. You go chest x-ray every 3 months, chest x-ray once a year, chest, sputum testing, all these. But now we have a non-invasive test to delineate patients who really need to be taken to EBUS ions versus not.
Thank you. Dr. Baptiste, now before I open this question to you, we have several more very good questions, so I'm going to limit you to about 30 seconds. Gaps, in your case, other than the gap of not having enough pulmonologists in the area, any gaps with multiple disciplinary teams that impact you?
No, I mean, I have a low threshold for involving my tumor board in some of these discussions with lung nodules. I think the CyPath, the benefit of it is it's less top heavy. Ion and navigational bronchs, as Dr. Gunakati mentioned, they're productions, and they take an hour, 2 hours. They take up OR space. So CyPath is, you get none of that. I mean, that's straight from the source, and it really is going to cover a lot of gaps that we aren't able to cover. There's just so many of us: physician extenders, pulmonologists, interventionalists, CT surgeons. There's only so many of us. So if you have one more objective data that's collected from a home specimen, I mean, how can you deny that?
Absolutely.
It's gonna be very important.
All right, Dr. Gouda, the next two questions will combine. They're both going to you. How would CyPath fit into your algorithm when you have an indeterminate, slowly growing nodule that falls between low risk and high risk? Where would you place CyPath in terms of surveillance, PET scan, or the biomarkers? And the next question, very similar, how would you see a non-invasive tool like CyPath fitting into an evolving standard of care for indeterminate nodules?
So I think this is the same question really. It's essentially utilizing a risk stratification platform. The really good questions. I'm glad this is a thinking mind that's asking this question. A lot of times we do see a lot of indeterminate, and that's why I said it depends on the kind of practice that you have. If your practice is predominantly being fed by oncologists, they need tissue. If it's predominantly being fed by the community, apart from the oncologist, then you're getting a lot of junk nodules, right? So these indeterminate nodules is the right place for you to use a risk stratification tool. Irrespective of the tool you use, and if the patient is able to bring up enough sputum for CyPath to actually be effective, then you are going to be able to get meaningful information to tell you this indeterminate nodule is actually very low risk. I really do not need to be worried about doing a CT scan every 3 months. I can push them out to 6 to 12. This indeterminate nodule is very likely malignancy. So let me set them up for a biopsy depending on what access to resources you actually have. When it comes to this, when the question is about evolving standard of care for indeterminate nodules, the challenge is not just about the nodules per se as an evolving thing. The nodules have always been there. Our understanding of them has changed, and our practice patterns have changed. And to make a more complex answer simple, it comes down to what resources that you have that you can actually evolve along with it. If you are in a large institution that is able to spend the money to get you robotics and create a production, 2 hours is a long time for a robotic bronchoscopy, but that's a separate conversation altogether. But you're able to get access to those advanced techniques to be able to perform biopsies, get cryoprobe, whatever it may need to be, then go for it. If you are in a community that doesn't have that access, you're limited by OR time, for whatever reason, then you are kind of stuck in risk stratification. You're putting the patient through a CyPath testing. Initially, if it's like less likely, but they grow in the next CT scan, repeat the test, because you may be seeing something now on the sputum test that you didn't catch before. So if the question is how many times do you repeat it, well, you could repeat it with every imaging study that you get if it's low likelihood, but there's still growth on the CT scan. At the end of the day, there is no study that is actually telling you that one risk stratification tool is better than the other and that can compete with clinical gestalt. If you're suspicious, repeat the test and maybe perform the biopsy.
Thank you. All right, the next question. What percentage of nodules do you end up doing CyPath Lung on? And does the specialty, in other words, interventional pulmonology versus surgery versus oncology, impact that? Dr. Gouda, what percentage of do you do CyPath Lung on?
Currently, we do about 30% of our patients get CyPath testing. Like I said, just because our clinic is we are going to be performing a biopsy on a lot of these nodules coming through. And our diagnostic rate is very high. It's over 90% for the biopsies that we conduct. And in larger nodules, over 95. And we diagnose malignancy at an alarmingly high rate. It's over 70% of what we biopsy, we get that back. Our diagnostic is malignancy. So we perform, CyPath is about 30% or so, in our practice is what we use it for.
Okay. Dr. Gunagante, what percentage of your patients do you do CyPath on?
Also there's a
obviously we're talking more about the ones you see.
Yeah, definitely. I think most of the time when I see a nodule with the previous history of cancer, or whatever, 1 or 2 years ago, or anytime, like I see a nodule, patient is in remission or done with the adjuvant treatment, and I see a new nodule, I go for CyPath. And then there was a question about what are the benefits of CyPath in patients patients in survivorship. Very good question. I see patients 2 years out, 4 years out, 5 years out. Now we have this survivorship. You beat the cancer. We're going to do scans. Oh, we found a 8.2 millimeter or 9 millimeter nodule. I'm going to tell the patient, okay, what is this, doc? and the radiologist says it could be malignancy, it could be inflammation, or it could be benign. I love that statement by radiologist CYA. So how do I answer the patient? Okay, what is this? Oh no, don't worry, we'll do another scan in 6 months. No, I do the CyPath to reassure them because of the negative predictive value. So I'm not very much concerned. It depends on the cuts you do on the CT scan. Let's do this test. We don't need to do biopsy. I want to watch it. So that decreases the anxiety of the survivor who has beaten the cancer and then now not worried about this new found 3 nodules in the upper lung, or lower lung, 1 nodule in upper lung. Yeah.
Dr. Baptiste, since they specifically asked about you, I suspect most of your patients have already been diagnosed and you're not doing a lot of CyPath, but what percentage of your patients?
Yeah, so I had 3 cases that were presented to me from Dr. Downey that were CyPath positive in the past. So I can really only attest to what I'll do in the future, and it's probably about 25% since I do run my own lung nodule clinic.
I think we have 1 minute to go. I will just give Dr. Baptiste, he didn't get to answer the question about the future. You've got 1 minute to tell us what the future is in terms of thoracic surgery. Anything different than now, or just earlier diagnosis and earlier treatment?
We're seeing data now with early lung cancer surgery that less is better, less resection is better, or certainly equal in a lot of regards for 1A and 1B lung cancer. So I'm thinking a lot of similarities with breast cancer and lung cancer. So that's all good. That's all good. I'm very excited.
So I think the genomic, last to finish up, we have been using genomic markers in stage 4 lung cancer. We used to say adenocarcinoma squam a few years ago. Now we are not doing that. We divide the lung cancer into 11 buckets. Same thing, we drag it to stage 3 and stage 2. In stage 1A, we don't need adjuvant chemo, but we can risk stratify by genetic information who needs adjuvant, who's at high risk of recurrence or low risk of recurrence, not paint a picture, a brush with the same brush saying, oh, all stage 1As are same. Let's see if they recur or not. So now we're translating it to the nodule level from stage 4 now to nodule backwards using genetic information than the clinical information.
Okay, and our time is up. So I'd like to thank our panel, first of all. I'd like to thank everybody for attending. And again, thank the Society for Advanced Bronchoscopy. Good night, everybody.
Thank you everyone for joining this webinar. Thanks to CyPath as well for sponsoring an excellent, informative discussion we had.
Well, this concludes the discussion with our multidisciplinary panel on navigating lower cancer risk nodules in high-risk patients using the non-invasive CyPath lung testing. Thanks to the Society for Advanced Bronchoscopy for hosting this program, and to our expert panel, Dr. Sussman, Dr. Gouda, Dr. Baptiste, and Dr. Gunagante. The full webinar will be available on the SAB YouTube channel. Thank you for listening.
Okay, thank you. And we have some questions. So the first one is going to go to Dr. Baptiste. I think you can see it in your chat, Dr. Baptiste, but I'm going to read it for everyone. In your experience, when performing wedge resections for indeterminate lung nodules, what percentage ultimately proved to be stage 1 lung cancers on pathology? You're muted.
I would say just over 50% are stage 1, because I tend not to, like most surgeons, we try to go in the OR with a PET scan with adequate clinical information to stage this patient clinically. I hate nothing more than to find a patient that has locally advanced disease unexpectedly. That's a real downer. And but the vast majority, I think the majority of people have stage 1 lung cancer when I deal with these uh, nodules that are zero point 0.8 to 1.5 centimeters and PET scan negative as far as the mediastinum. I think that this test is going to be very important. I kind of look at it in the sense the way we looked at breast cancer in the 80s and early 90s when breast cancer became a local disease and they needed neoadjuvant chemotherapy and radiation. And when patients got operated on, ultimately had a modified radical or lumpectomy, sometimes there was no tumor to be found. And my hope is that lung cancer is going to kind of go the same way with neoadjuvant therapy in patients with stage 1 lung cancer. I think that's where we need to go, and I think that's where we're going to be found ultimately. But I think that um, that this test is going to be very helpful when it's negative, and it really prevents us from doing biopsies that aren't necessary. I hate doing lung biopsies that are granulomas or they're fibrous tissue or they're just negative. They're junk nodules, as Dr. Gouda says. I like that term, junk nodules. I really think that a negative predictive value is going to be very helpful in not having patients go through unwarranted biopsies. So.
Yeah, I think that's an excellent point. It's not just that our goal is to pick up these lung cancers early in stage 1A, but also to avoid unnecessary biopsies or in some cases resections on those that are not malignancy. And again, that's where the negative predictive value comes in.
Well, this concludes the discussion with the multidisciplinary panel on navigating lower cancer risk nodules in high-risk patients with non-invasive CyPath lung testing. Thanks to the Society for Advanced Bronchoscopy for hosting this program, and to our expert panel, Dr. Sussman, Dr. Gouda, Dr. Baptiste, and Dr. Gunagante. The full webinar will be available on the SAB YouTube channel. Thanks for listening.